Hello, everybody. This is Dr. Craig Thomas in Dallas, Texas, and welcome to CE Wire 2017. Today we're going to have a course on amniotic membrane therapy called The Good, the Bad, and the Ugly. We will talk about all the things about amniotic membranes, all the good stuff they do, and the occasional funny or bad things that they do, so that we can all use these therapies for our patients. I do have a couple of financial disclosures. I am a paid speaker for BioD. I'm also a paid speaker for Conan Medical. BioD does make dehydrated amniotic membranes, but I'm not going to give a commercial. This is a class. So what is amniotic membrane? Amniotic membrane is one of the layers of the placenta. You see the diagram of the placenta there on the right-hand side of the screen. You got the epithelium, the amnion, the chorion, and all the intermediate layers that go in there. I want to thank Blythe Medical for letting me use this recreation. And the thing that's in amniotic membrane, it's two primary therapeutic things, these growth factors and these cytokines that modulate metabolic activity. And the amniotic membrane contains an extracellular matrix that has specialized proteins that promote and accelerate the wound healing response. We'll go into detail about that later. There's all sorts of interleukins to downgrade inflammation, and this heavy chain hyaluronic acid that suppresses pro-inflammatory cytokines. So lots of chemicals in the membrane, lots of things, signaling molecules, all sorts of stuff to affect the immune system. That's what amniotic membrane is. So the first question, what are we doing here? What is this stuff? This is what it is. What we're doing is delivering or prescribing regenerative therapy. Regenerative therapy where you use some part of the body to heal itself. Human amniotic membrane allografts are tissue-based products, and we use these discs. The majority of this lecture is going to be talking about dehydrated amniotic membranes, but some of it will include cryopreserved membranes. I have clinical experience with both types of technology, but the emphasis here is going to be on the dehydrated product. So we're using these products, whether they be dehydrated or cryopreserved, especially in the optometric field. We're using them as a biological bandage to promote healing of the surface, the ocular surface. You can see in the bullets all the ways that it does this. The membrane is a source of undifferentiated stem cells and so on. So lots of positive things, lots of beneficial things here in the membrane, all these growth factors, chemicals, and it has the effect of reducing inflammation, preventing scarring and fibrosis, prevents vascularization, suppresses pain, lots of good things here, all sorts of good things that you get when you put amniotic membranes on some body. So that's what regenerative therapy is. How do we use amniotic membrane? Well, it has two primary usages. One is as a surgical graft. Most optometrists are not going to be doing this, at least not now. When you use it as a surgical graft, and I have had patients where we've had to do this. I've had patients with corneal perforations, and we've had to do this stuff. So the allograft is sutured on, and then it integrates into the patient's cornea. It kind of blends into it, and it's used as a graft in that sense. Well, that's not what we're doing. What we are doing is using the amniotic membrane as a biological bandage. And in this scenario, the allograft, the disc, the piece of tissue, is placed on the patient's cornea, and it acts as a temporary dressing to treat ocular surface disease. And although these terms seem so simple, temporary dressing, I actually looked up in the medical dictionary, biological bandage, dressing, and just to get a refresher on these terms. And it's almost as simple as it sounds. A dressing is something you use to cover up a wound, and we'll get again into more of that a little bit. The second thing here on these biological bandages, the way that optometrists are using amniotic membranes, is when the membrane degrades. Essentially, what you're doing is you're putting this membrane on the ocular surface, and it is a drug delivery vehicle. The drug delivery vehicle that releases bioactive components, signaling molecules, and these chemicals target the eye and the brain by stimulating the patient's immune system. It's just a bunch of chemicals is all it is. When I looked up dressings and bandages, what I found interestingly, so you can have a dressing, you can have a bandage that you put on a wound, and you can also have nowadays what's called an impregnated bandage or an impregnated dressing. And the most common usage of that is where you would have antibiotic blended into the bandage. And when you put the Band-Aid on someone, it actually releases the antibiotic at the same time that it's covering the wound. That would be an example of an impregnated dressing. That's essentially what these amniotic membranes are. They're impregnated dressings, and they're impregnated with a bunch of chemicals made by the human body instead of being made artificially. And then as the membrane degrades or dissolves or resorbs, it releases the chemicals onto and into the ocular surface. It's no different than us prescribing any other medicine. It's just like us prescribing a bottle of Tobradex or a bottle of Vigamox. So I can deliver drugs. The drugs are in that bottle. I can deliver drugs via a solution that the patient puts in their eye with an eye drop. I can deliver drugs via an ointment. So the ointment could be the delivery vehicle. It's got all the chemicals and drugs in it, and I can put the medicine in the patient's eye that way. I can prescribe pills, and I can deliver drugs or medicine or chemicals orally where they absorb it systemically. And now I can deliver drugs or chemicals or medicine via an amniotic membrane, and that's simply the delivery vehicle. So it's really not complicated when you think of it like that. I'm just prescribing medicine that's delivered a different way, and the medicine is made a different way. The medicine is made by the human body, and I'm putting it on with an impregnated dressing, which is this piece of tissue, instead of a drop or an ointment. That's how you're using the amniotic membrane. The next logical question is, how does the thing work? So how does the amniotic membrane do its job? Well, it affects the immune system. And remember, the immune system is a biochemical complex protecting the body against all sorts of infection and injury and things that go wrong. And it's all chemicals. There's nothing physical going on. It's chemicals being released, chemical reactions. That's how the body works. So it works on the immune system. Well, since it works on the immune system, you can have all sorts of potential responses. And although all the companies that make these products, whether they be dehydrated or cryopreserved, the goal is to produce a product that's antigen neutral. Every single amniotic membrane that's made in this country right now is capable of producing an immune reaction known as an allograft response. And this allograft response is a type of allergic reaction, and it happens in individuals because these membranes contain non-self low molecular weight peptides and residual DNA that the person can recognize and unfortunately sometimes react to. So they work by affecting the immune system, and they affect the eye and the brain together. So it's not just an eye thing, it's a brain thing too. When would you use amniotic membrane therapy? And that's the correct term, is amniotic membrane therapy. And you conduct a therapy session when you put the membrane on, and the session lasts as long as the membrane stays on or till it dissolves, and you remove it, or if it's a dehydrated one, you take the contact lens off. So when you would use these things is one of three scenarios. The first, as you see on the slide, and it's important enough to read out loud, when medical management fails. So you would consider using an amniotic membrane on a person's eye when you've tried regular medicine, regular drops, regular ointments, and it's not getting the job done. The second indication would be if that same medical management is not tolerated. So you can have a toxic reaction from some type of aminoglycoside, like in Tobrex drops. You can have allergic reactions to preservatives. You can have any number of things can make a treatment produce side effects where the treatment is not tolerated. And last, you can have scenarios where the treatment is contraindicated. So you could have patients with certain types of ulcers where you don't want to use steroids. You can have patients where you have standard therapy that may not be good as updated therapy, particularly in cases like recurrent corneal erosion, where to me amniotic membrane therapy may be better than standard bandage contact lens therapy. So if the old therapy is not as good as the new therapy, is the old therapy contraindicated? So the three clinical indications or circumstances are when medical management fails, isn't tolerated, or is contraindicated. Fortunately for us, most of the insurance companies and carriers in the country do not have any set policies on amniotic membrane placement, and you don't have to stair-step your treatment. You don't have to start off using artificial tears and go to Restasis and go to Xiidra and go to Lotemax and go to this and go to that before you get to an amniotic membrane. You can do whatever's in the patient's best interest and whatever is reasonable and medically necessary in your opinion. So within reason, there's not a whole lot of rules and regs that go along with this. You can kind of do what you want when you want most of the time. The only Medicare LCD where they have rules and regs regarding this procedure is in the state of Florida, at least right now. That may change later, but right now there's essentially no rules that govern the provision of this service, and that's a good thing for us. Treatment guidelines. So you've decided that you're going to try and help somebody's eye get better by putting an amniotic membrane on it. Well, you know, this is all new stuff for us. We haven't done this before. So these are an example of our treatment guidelines, and there's 3 potential outcomes when you're using amniotic membrane therapy. The first potential is you would have complete success. So whatever condition you were trying to treat, one of these things on this bulleted list here, dry eye or band keratopathy or recurrent erosion or whatever it might be, corneal ulcer, you know, I talked about an ulcer patient a few weeks ago on OD Wire, whatever the condition may be. So the first thing is you could put your membrane on the patient, and whatever you're trying to fix, you fix it right then, first time. It's great. So you can have complete success, which is, I would say, the majority of the patients that I've done. You know, so if I've done 100 patients, if 51 had complete success, that'd be the majority. So I mean, I'd say the majority have complete success, but not all. The second group of patients are going to have partial success, where you put the membrane on, they get better, but whatever you were trying to fix is still there at the termination of the therapy session. If you've determined that you have partial success after your therapy session, then you would kind of step back and reevaluate and decide how do you want to proceed. You might kind of just leave it alone, do your one treatment and go from there and just kind of see how good they get. You might put bandage contact lenses back on the patient or on the patient for the first time. You might repeat the amniotic membrane placement if you think it's necessary. There's not a whole lot of rules that say you can't do that. There's no rules really. You can go surgical and start getting tarsorrhaphies, all kinds of things. But the main thing is if you have partial success, to me you're not finished, and you have to decide how do you wish to continue, whether it's, you know, pivoting and going in a different direction, or perhaps repeating the placement procedure. And I have definitely seen patients where they got better after one treatment, they didn't get fixed, and we did it a second time, and they continued to improve. I am generally of the opinion that you treat a patient that is getting better until they stop getting better. So I would generally keep going until I proved that they couldn't get any better. So if I did it once, it got better but was still there, I'd have absolutely no problem doing it a second time and seeing if they got even better then. I've had a few patients that I've done 3 times and a handful that I've done 4. So sometimes partial success and you've got to retreat or do something else. And then the third potential group of patients would be defined as failure of the treatment program or the therapy session. And the failure is defined, as you see, as they didn't get better. And sometimes it doesn't work. You know, nobody's perfect. These things are all different. Patients are all different. So sometimes you put a membrane on somebody trying to make them better. They wear the thing. It doesn't make them better. You take it off and they're the same. Okay, well, that would be a failure. The second type of failure is where you have to prematurely terminate the procedure, generally because of some kind of complication. It could be the membrane moved, some kind of allergic reaction. 4 or 5 things can happen, and we'll talk about them toward the end of the presentation, post-operative or operative complications. But those things would all result in failure. So failure is if they don't get better, or if you have to stop trying to make them better by taking the membrane off before you really wanted to. So you can have complete success, partial success, or failure as your 3 potential outcomes. So these are our treatment guidelines when you're prescribing amniotic membrane therapy. Let's talk a little bit about the technology. There's essentially 2 types of amniotic membranes. There's the dehydrated product and the cryopreserved product. There's several companies in the United States that make dehydrated membranes, probably 7 or 8, maybe 9 or 10. I've used 4 different ones trying to get clinical experience and seeing if there's pros or cons between them. I've also used the cryopreserved membranes, the ones that are frozen. That was my first clinical experience with amniotic membrane therapy, and I had some success, but they're different. In the dehydrated product, you prepare the tissue by essentially dehydrating it. I mean, I'm simplifying it. It's quite complicated, but you dehydrate it. The other technique with the cryopreserved, you freeze it. In the dehydrated product, you have a small disc that you put on the cornea, and then you retain it with an overlying contact lens. In the cryopreserved product, the membrane is fastened to a plastic symblepharon ring, a little plastic ring, and so it's a device. So the cryopreserved technology is actually classified by the FDA as a device, where the dehydrated product is not. The dehydrated product is regulated by the Public Health Service, as you see there. The cryopreserved product is regulated by the FDA. So 2 different kinds of products, and unfortunately, I hate this. There's unfortunately an element of he said or she said. My fire is hotter than yours. My membrane is better than yours. Is there a difference between the technologies? Is one product better than another? Is one product safer than another? Does one product last longer than another? Who knows? I've been doing amniotic membrane therapy for a little bit over 3 years. I've done about 330 procedures at the time of this presentation, most of them dehydrated, but I started out with the cryopreserved, and what I have seen is that all amniotic membranes work, and all amniotic membranes cause problems. There's no difference really in the technologies. The differences are significant in other areas, but they all work. There's some representatives and companies that would say their product is different or better. My clinical experience does not match that, and I believe that all these membranes have pros and cons. One of the questions that you would ask when people start trying to say one membrane is different or better than the other is, what happens to the thing when it's being processed, the structural properties. And there's all sorts of, the science is really kind of intense. How does the preservation affect growth factor retention efficiency? So again, you're putting this membrane on the cornea, and it's got all these chemicals, these growth factors. So do the growth factors release onto the ocular surface real fast, like in 20 or 30 minutes, or does it take hours and hours and days for the stuff to be released and diffuse into the tissue? So you can have preservation technique affecting the growth factor retention efficiency. You can have it affecting the biochemical factor time release. How long does it take for the stuff to kind of leach out into the tissues? I mean, a lot of science, a lot of stuff going on here. Some of this stuff we can't prove, and you just have to simply go kind of with your anecdotal experience and what you see over time. But I want you to, from my point of view, there are no obvious extreme superiorities, cryopreserved versus dehydrated, as far as efficacy, and they all have pros and cons, and I don't think we should be arguing about if one's better than the other. Some amniotic membrane therapy is better than no amniotic membrane therapy, so I'm just encouraging optometrists to try to prescribe amniotic membrane therapy. Do something. That's what I'm trying to do. This is what these things look like. You see on the left hand the dehydrated membrane in its little sterile pack. It's my partner's hands, Dr. Burton, kind of snagging one out with some forceps. On the right hand side you see the cryopreserved product. Right now the only one is made by BioTissue. It's called Procara. You see the device down there being held with some gloved fingers, and you slip it in the eye. So these are your 2 different types of amniotic membrane allografts: dehydrated, cryopreserved. So let's talk about some patients. We've got a little bit of references as far as what is amniotic membrane, how do you use it, what is it for, how does it work. So we've got a little bit of that. I mean, this stuff's complicated. I can't go through it in a 1-hour lecture to where you're a master, but I want to give you a taste of it to where you can do your own learning, your own independent research, and keep going. here is how I got really hooked on amniotic membrane therapy. And I've described several of my cases through the years on OD Wire. The very first one, this 90-year-old guy that I had 3.5 years ago, the first one, I have seen these things almost perform magic on people's corneas and their ocular surface. It's really incredible what they can do. And once you see it for yourself, just a couple of 3 or 4 times, most of the time I think you'd be hooked and you say, wow, I can really help my patient with this therapy in a way that I could not help them any other way. And I've tried all the things that we can do for ocular surface disease, all the autologous serum, and all. I mean, I've gone way out there, you know, and I'll stay out there. But this is definitely a mainstay of my ocular surface disease treatment right now. So this patient here is an example of what I have seen and what got me hooked on this to try to help my patients. So this lady here, these are all, every slide, every picture is one of my real patients. So this 70-year-old lady is one of my patients, and this image that you see is a picture of her from a couple of years ago, back in November of 2014. You can see just by the clinical experience, she's got moderately severe dry eye, she's got epithelial staining, corneal staining, she had some filaments up at the top of the cornea, she's got bad dry eyes, she's very uncomfortable. This lady's probably been seeing me for 10, 12 years. Most of you guys that know me, ladies that know me, I'm fairly aggressive, fairly modern. You know, I'm going to try almost everything, almost every time. So in the years that I've been taking care of this lady in her dry eye, and she has glaucoma too, I've tried most standard treatments for ocular surface disease. Artificial tears, unpreserved tears, steroids, non-steroidal anti-inflammatory agents, bandage contact lenses, punctal occlusion, Restasis. I've done, you know, I mean, that's a lot, you know, over several years, trying to make this lady look better and feel better. And despite all of that, when I saw her in 2014, after working on her for at least 10 years, this is still the way she looks, despite me doing all of that work. So imagine what it would be like if I hadn't been doing all of that stuff. It would be horrific. So this is what she looked like. So this lady came in, this is when I first, in the context of this case, it's about a year ago. So this was about January, I think, of 2016. So this lady comes in, yeah, January 2016. So this lady comes in, and their standard deal, you know, hey, my eyes are bothering me, feel like I got rocks in my eyes, is there anything you could do to help me? You know, I'm looking at her, you know, and this is what I saw, the picture, this picture right here. So this is what I saw on January of 2016. Look how similar it is to November of 2014. So here she is, January 2016, got all the staining, all the cell damage down here, just like she did before. I had done plugs 2 months earlier, so as recently as November, I'm sorry, in August of, so I'd done plugs 5 months earlier. So I tried plugs twice with little improvement. Steroids, she's taking Lumigan for glaucoma, and using unpreserved tears. So she comes in for a visit, you know, same thing, I'm seeing the same thing. But this time, I had just started doing the dehydrated product. I'd been doing the cryopreserve amniotic membranes for a couple of years, and I had determined, just based on my experience, that this particular patient was not a good candidate for the cryopreserve product. The ring is very large and can be very noticeable to many patients. It can be uncomfortable to some patients. And based on my experience, you know, after just trying and failing a few times on some people, rather than open up that real expensive product, I sometimes now I just kind of eyeball them. I'm like, no, she can't do it. I'm not going to even try. You know, I'm not going to even open the pack up. I'm not going to try it. So this was a patient where I'd already made the assessment I was not going to try the cryopreserve product, even though I had some good experience with it. I just determined that she was not a good candidate because of her eyelid tightness and other factors. So I said, well, now, and this was again about a year ago, and I just begun using the dehydrated product, I said, let me consider something different. Let me put a dehydrated membrane on this lady. And so I did. And you see on the right hand side what her cornea and conjunctiva looked like 2 days after beginning the amniotic membrane therapy session. To me, it was dramatic. So I put this membrane on her, put a contact lens on top, had her sleep in it. She comes back 2 days later. I say, how do you feel? She said, I feel fine. I take the contact lens off, put some dye in. I don't see anything. The little bit of lissamine green staining that you see right here is from the edge of the contact lens, where the contact lens was a little bit too tight. But all the cornea and the conjunctiva that was affected by the amniotic membrane, all that stuff looks 100 times better. As soon as I took the membrane off, the contact lens, and I looked at it, I was just astounded. She said she already felt better, and I was almost flabbergasted and just, slack-jawed to where I couldn't believe how much better this lady's eye looked after 2 days of wearing this membrane. I had seen results like that previously with the cryopreserved, but again, I kind of stopped doing a lot of them because the cryopreserved just are so big and noticeable to so many people. I'd begun to shrink my patient selection down to, a small number. This got me hooked. This lady got me hooked. So I decided to keep going. And almost magically, as I decided to keep going, people started streaming into my office with all sorts of weird ocular surface disease or injuries. This lady's an example. A 78-year-old lady, she poked herself in the eye putting on her glasses. Sounds comical, but, I've seen it 7, 8 times. And, of course, she's waiting 2 days to see if it would get better and go away on its own. Of course, it didn't. And then she presents, first thing in the morning with an emergency saying her eye is killing her. She's sensitive to light, the eyes watering, her eyes red, the lids droop down, she's in pain. And it was pretty obvious what was going on. So she had a large corneal abrasion that had failed to resolve on its own in at least 48 hours. Well, I took one look at it, and I'm thinking, man, that's a big one. I could have maybe pressure patched it. I could have possibly put a bandaged contact lens on it. I could have done what, unfortunately, I see some doctors do and not cover it up at all and simply put her on some topical antibiotics and tell her to grit her teeth and it'll be better in a day or two. It'll be better, it'll be better. Okay, fine. Or I could prescribe what I consider to be the top of the line best therapy, which is to put an amniotic membrane on that thing and try to make it heal up as fast as possible. And because of all the things we talked about at the beginning of the presentation, to try to prevent complications down the road. Most of us have seen abrasions like this lead to recurrent corneal erosions down the road. And so the better you heal this thing up right now, the less chance you have of that going on down the road. So there are many reasons why I chose amniotic membrane therapy as my first treatment option on my first visit. Another patient, this is a patient with a different pathology, a man with chronic postoperative corneal edema, secondary to cataract surgery and complications from that. This particular patient had been suffering for years with chronic discomfort in his right eye. He had been in the ophthalmology practice that had done the surgery, got transferred to a retina specialist because he had endophthalmitis after the surgery, part of why his cornea got messed up. And he was just pretty much miserable every day of his life since his eye had been worked on 5 years earlier. One of his relatives sent him to me, and he came in saying, please help me, my eye's killing me. Well, I'm like, hey, I got just the thing for you. We got these brand new dehydrated membranes. I put a membrane on him. 2 days later, he came back, and he said he felt 100 times better. This is that patient. I left it on. He came back 2 days after that. It was still there after 4 days. And sometimes they take a while to dissolve. Generally after the 4th or 5th day, if it's still there, I'll go ahead and take the contact lens off because I think we've got whatever benefit we're going to get. That's just the way I'm thinking. I don't have any proof of it, but 4 or 5 days is about my max on one of these things as far as the dehydrated ones. When I'm doing the cryopreserved, I've gone as long as 6 or 7 days with one of those, excuse me. So this is what it looked like toward the end of the therapy session. Here's another patient, and what I'm trying to do here is just demonstrate the wide range of conditions that you can use amniotic therapy on. I have doctors all the time, they'll come up and say, Craig, who can I use this on? What can I do it on? That's what they'll say. And I'm like, whatever, whatever you want, really. Whatever the evidence says, whatever the literature suggests. I mean, you can't just make up stuff. But my feeling and my experience is that most forms of ocular surface disease can be impacted with amniotic membrane therapy. And here's an example of one where you may not think so. You know, an 81-year-old lady with Fuchs dystrophy complaining of chronic foreign body sensation and hyperlacrimation and decreased vision. She came in on an emergency because she said her eye was hurting. You see here down in the lower right what the cornea looked like when I put fluorescein in. You can see this large area of edema where you have the negative staining. And I had seen this lady 4 months earlier, and that thing was not there. So this was a new development. Her cornea was getting worse. Her Fuchs dystrophy was getting worse, and to where it was obviously clinically significant. Well, I mean, she's already on hypertonic solution in addition to her glaucoma drops. I mean, how many drops can the lady put in her eye all day long? She's on 3 glaucoma drops and hypertonic solution. Well, I decided, hey, let me just make this easy on me and her, and I put an amniotic membrane on her. I left it on 4 days. She came back, and after I took it off, this is what the cornea looked like. You can see a little bit of stippling there, like you would get maybe from any kind of tight contact lens. You can still see the lesion. The lesion is still there. It didn't go away. I didn't expect it to go away. But it is significantly reduced in height. It doesn't look as angry. And when I took the contact lens off and asked the lady how she felt, she said she felt fine. And she definitely said she felt better than she did 4 days earlier. And I said, well, you know, what do you think? You know, did it help? She goes, absolutely. I said, do you want to do it again? She goes, yeah, sure. And I did it again. You know, and I stopped after the second one because she didn't really get a lot better after the second one. But, you know, I mean, I waited about a week and then I did it again. You know, so to me, she had partial success after her first therapy session. So I decided to retreat her as my next option. And I can do that, and there's nothing wrong with that. So here's an example of that. And I've done her twice. This was probably last April. She's been fine since. So kind of a good example there. This guy here, this guy had a neurotrophic ulcer. This was no, this guy has band keratopathy, okay, with a neurotrophic ulcer. And you can see the ulcer right there, okay, right here. Excellent article in Review of Optometry talking about persistent epithelial defects, these neurotrophic ulcers. You know, this patient has band keratopathy, had diabetic retinopathy, retinal detachment, all kind of bad stuff. That's how the cornea ended up like this. But right now, this guy was in pain a lot. So I put a membrane on it. And this particular one, see here, that's right, I do remember now. This particular one, here's an example of the cryopreserved membrane, the Procara membrane. So you see the large device, there's the ring right there. Okay, the amniotic membrane is all right here. You can see a little bit of a fold of it right there, a little bit of the overlap that comes around. It's kind of caught right there. So this is what the Procara device looks like when you put it on the eye compared to what an amniotic, the dehydrated. See right here, here's the dehydrated membrane right there. And quite a bit of difference with the cryopreserved product. Here's the amniotic membrane, but it's held in place with this plastic ring that you tuck up under the eyelids, okay? Putting the membranes on, the dehydrated ones, I've got pictures here. And again, I'm concentrating on dehydrated membrane technology in this presentation. Number one, because it's a little bit newer. There are several classes around now at most of our large meetings, all of the Vision Expos and SECOs and things like that, that are talking about amniotic membranes. Unfortunately, from my perspective, they are somewhat limited, most of them, especially in the early years, you know, just a year or two ago, where they focused almost exclusively on the cryopreserved products. And again, that's what I started with. And the cryopreserved product is relatively easy to insert and remove. You just kind of grab it and put it in and take it out. So it's not that big a deal. The insertion or the placement of the dehydrated membrane is quite a bit more involved and more sophisticated. So you've got a much more complicated insertion procedure. But the benefit or the result of that is you've got, in my mind, a product that's much more wearable for the patient. You've got a much higher patient acceptance because it's physically more comfortable for most people. So when you're putting the dehydrated product on, you've got two ways to do it. The pictures here, I'm showing you how to do it where you use a lid speculum. Some of us have training on applying and removing the speculum. Some of us don't. It's not that hard. It took me a few days to learn how to do it, watching my partner do it. My partner learned how to do it going to a seminar. So you can do it like this. What we found out very quickly is that this is not necessary most of the time, and the vast majority of the time, I'd say 97% of the time, if I put a dehydrated membrane on a patient, I do it with a freehand technique where I don't use the speculum, and I simply have one of my optometric assistants manually pull the patient's eyelids apart while I put the membrane on. I've gotten reasonably skilled at it to where I can do it in just a minute or so. We can do it all real fast. I've got 2 people in the room helping me. But if you're going to do the speculum, this is how you do it. The benefit to the speculum is you maintain total control of the surgical field. You don't have to move fast at all. You can kind of be nice and deliberate. The disadvantage is, to me, it's a little bit more uncomfortable for the patient, a little bit more skill involved, and quite a bit more skill involved at removing the speculum after you put the membrane and the contact lens on, because you've got to make sure you don't dislodge either of those things when you take the speculum off. So to me, the speculum's benefits do not outweigh its disadvantages, and most of the time I do not do it, but this is how I started. But now I just have one of my assistants with short fingernails pull the patient's eyelids apart while we lay them back. So that's how you put it on. Reporting the procedure is relatively easy. The CPT code is 65778. This is a high reimbursing procedure, as most of us already know. That's probably why some of us are listening. There's a lot of money here, but the products are expensive. So I mean, you know, they go together. You got a bilateral surgery modifier that applies if you do both eyes. Out of my 320 plus cases, I think I've done maybe 5 people bilaterally. A couple of them were thermal injuries or chemical injuries where both eyes were injured by burns, and I wanted to treat them both at the same time. Once or twice it was somebody traveling where they wouldn't be able to come back for a second procedure. But most of the time, almost all the time, you want to do one eye at a time. There's a 0-day global period, so if you put the membrane on Monday and you see the patient on Tuesday, if it's reasonable and medically necessary, you can bill an examination on that second day. So it's a per visit thing. And as I've said several times, the procedure can be repeated as needed when it's reasonable and medically necessary. My max patient, I've had 2 patients that I've done 5 procedures on in the year 2016. I mean, so that's, you know, 2 people out of 320. I mean, so not a lot. You know, most of the time, you know, once or twice is going to get it done. You know, a few people you may do 1 or 2 sessions and maybe another session 4 months later. But once or twice is going to get it done for most patients in my experience, but not everybody. And if you need to treat somebody 5 times in a year, and then that's what you need to do, and there's nothing wrong with that. And we should all understand that. There's nothing wrong with that. We're doctors. This is no different than some retina specialist injecting somebody with Avastin every month and charging Medicare $2,200 every month. We've all seen that. We've seen these guys put these shots in people's eyes with hand motion vision and 2400 vision. We've all seen that stuff and shake our heads, you know, and watch these guys do these $2,200 injections I have one lady that had 25 injections over like a 2.5-year period. Every one of them was $2,500, $2,200, every one of them. It's crazy. So if I want to treat somebody once or twice or even 3 times because I think that's in their best interest, I don't have a problem with it. I'm not doing it to make money. I'm doing it to help my patient, just like you would be, and there's nothing wrong with that. So that's how you report the procedure. So let's finish up here and talk a little bit about complications. Remember I said the title of this presentation, amniotic membrane therapy, the good, the bad, the ugly, okay? Well, I've talked about the good. The good is real good. These things are great. I love them. I'm never going to stop. I've helped so many people get their eyes healthier and feel better and see better. I'm proud of myself. So I'm definitely not going to stop. However, these things are not perfect, and they do have some negatives. There's some ugly here. So let's talk about complications, because that, you know, I could spend all, you know, the easy part is easy. So if you put one on, take it off, it works great. You look like a master and you didn't hardly do nothing. Okay, well, I don't have to teach you how to do that. That's real easy. You can knock that out tomorrow. I got to, it's what happens when there's a problem. That's when they start calling you doctor. That's when they call you at 10 o'clock at night. That's when they call you on Saturday afternoon, is when there's a problem. So here's how you earn your money. So the first thing, let's talk about patient intolerance. This is my clinical experience. When I was using the cryopreserve product, I had a patient failure rate approaching 50%. And almost always it was due to patient discomfort, where people couldn't tolerate wearing the thing. I had patients where I would put the membrane on at 10 in the morning, and they'd come back at 3 o'clock in the afternoon and say, hey, take this thing off. I can't stand it. I'd have patients where I put the thing on at 10 o'clock in the morning, and I'd make them hang around in the office for 30 minutes or 45 minutes to see if it would get comfortable. And they would say, hey, take this thing off, before I could even get them out the office. I had patients where I would have to tape the eyelids shut. I'd have to put a piece of tape on the top eyelid or the bottom eyelid, trying to get it to where the patient couldn't blink a lot and they wouldn't feel the thing. I actually had a couple of patients, I was almost scared to do it, but I did it, where I patched their eyes shut while they were wearing the cryopreserved membrane. I mean, just being desperate, trying to help them, but they were complaining so much about physical awareness, I didn't know what else to do. And so I tried patching them. And most of the couple times I tried that, it didn't work well at all. So to me, you've got a significant amount of patient intolerance with cryopreserved allografts. When I was at Vision Expo last year, I went up to the Senior Vice President of Biotissue and asked him directly. I said, sir, what is the company's line? What's the company's spiel? What do you guys tell your customers, the doctors, to expect as far as patient intolerance? And the words from the Senior Vice President's mouth was 10%. So to me, that's your low bar. You should expect a 10% failure rate starting off no matter what you do. So if you try 10 people, at least one of them's going to say, hey, I don't like this thing, take it out, I can't stand it. Okay, well, I can live with that. I couldn't quite live with 50%, and so I started looking for other options. But everybody's going to be different, every practice is different, every doctor's different, patients are different. Clearly these things work, and I know many doctors that did not have and do not have a 50% patient intolerance rate. That was mine. So it's going to be somewhere between these two numbers. That's the first thing. And when the patients can't wear it, the good part about any of these products is, hey, you just take it off. That's the good part. Just take it off and it's all fine. The second complication is poor surgical technique, and this is exclusively with the dehydrated product. There's little technique involved in putting on a cryopreserved membrane. You essentially have the patient look down, snag the top eyelid and pull it up, slip the membrane up underneath it, the device, and then you have them look the other way and you slip the bottom of the device up under the lower lid. It takes 10 seconds. It's pretty easy. The only thing, all the prep in that is rinsing the solution and stuff off. So surgical technique, almost exclusively, we're talking now about applying a dehydrated membrane to the cornea. So the first thing, you can have corneal abrasion or membrane dislocation secondary to putting the speculum on. I talked about that. I had that happen to me one time where I didn't know what I was doing until I got better. The second thing regarding technique is you can have allograft instability secondary to poor corneal preparation. And I'll show you a picture of that in a minute. So and I've had many doctors from around the country call me over the past year saying, hey, Craig, I put a membrane on and, I looked at the patient 20 minutes later before they left and the membrane was, halfway up their nose or something, it slid off their eye. And I'm like, hey, you didn't put it on right. These things can be like Teflon. And different companies, the different brands, the different types of dehydrated membranes, they all have different handling characteristics. Although therapeutically, I've seen pretty much similarities between them, they do have differences as far as kind of how they're designed and how they handle and how you put them on. And some of them appear to be stickier than others, where some of the membranes slide around more than others. So you've got to prepare the cornea to keep that from happening. I'll get a little bit of that. And then the last thing, it sounds so simple, but it is very important, is you got to have the proper cornea contact lens relationship. If the contact lens is too light or too tight or too loose, You can have problems just from that. If the contact lens is too tight, the eye could get red, and you can have problems there. If the lens is too loose, it may not hold the membrane in place, and you'll have membrane instability or dislocation, and the thing will slide out from underneath the contact lens. So those are your three possible technique-related complications. And the big thing with the preparation, corneal preparation, so when you put the membrane on, you've got to prepare the cornea. And I think you see this picture of my associate, Dr. Burton, my partner, actually preparing the cornea. You see he's got that Wexel sponge, that surgical sponge in his hand. And what he's getting ready to do is he's going to brush the corneal surface, kind of stroke it, brush it. And what he's doing, he's going to get off any loose epithelial cells, any debris, get rid of that stuff, scrape that stuff off of there. Then he wants to basically eliminate the microvilli that are sticking up, kind of scrape those things away. Because what you're trying to do, what you're doing, is you're turning the corneal surface from its normal hydrophobic posture to making it hydrophilic. So normally the cornea is hydrophobic, where it's repelling water and repelling everything. When you scrape the surface, get rid of all the loose epithelial cells, get rid of all the microvilli, you turn the corneal surface into hydrophilic, where it attracts water, and it'll attract the membrane and get that capillary action to make the thing suck down and stay in place. And if you don't do that, it doesn't suck down and stay in place nearly as well, and it can move. Here's an example. Here's a picture. So here's a picture of a dislodged membrane. So I put the membrane on. This is early on when I didn't know what I was doing. I wasn't preparing the cornea. I would say, man, this is so easy. I don't know how it's so easy. I'd put the membrane on, and sometimes it would work fine. But I had a run of maybe 5 or 6 patients like this over a month or so before I realized what I was doing wrong. And this is what it can look like. And I've seen this presentation several times. This is actually the membrane folded up under the contact lens. And once this happens, there's nothing you can do to straighten it out. You just got to take the whole thing off and either call it a day or start over again later. So this would be described as failure. So the outcome here is failure. And then you would have to decide, do you want to try again or do something else? I would try again and just prepare the cornea better. Here's what one of these things looks like before it's dissolved. I just snagged it up with some forceps just so you could see it. Also, you got to warn your patients not to rub their eye too hard, especially that first day, that first time they get in the shower. I've had a couple of guys where everything was fine until they took a shower the next morning, just fool around, washing their face and rub the whole thing out. So you got to kind of just be a little gentle for a few days while you've got the thing on, as far as rubbing your face, rubbing your eyes. The most serious complication is rejection. This is the ugly. This is the ugly part of amniotic membrane therapy, and it's nothing to be afraid of. It's there. There's ugly parts to many things that we do. Any of us that prescribe contact lenses, we've all seen contact lens-induced peripheral infiltrates and ulcers. I've had a couple of patients actually lose an eye secondary to wearing contact lenses. There's risk involved in what we do. I've had patients develop steroid-induced glaucoma after treating their uveitis. I've had all kind of bad stuff happen to people in 33 years. That is part of our job. And as long as we manage the risk, educate the patients, do our job properly, it's a risk that can be dealt with. So you have a risk, and in my experience, the risk is 1 to 15%. Okay, you probably talk to the companies; they're going to say 1%. You talk to me, it's 15%. So, if I line up 100 people and I put amniotic membranes on them, 15 of them might have a reaction. Now, that means 85 of them won't, but 15 of them might. Some docs may say they're not comfortable with that, then hey, don't do this. I can deal with it. It's okay. I can handle it as long as I know what it is. So I'm getting ready to tell you what it is so you can handle it. It's not too big a deal. So you can have a rejection episode where essentially the person is allergic to the membrane. These things are tissue-based products. It's a piece of tissue. It's no different than me putting a kidney in you, and you might be allergic to that kidney and reject it. Well, I'm putting this amniotic membrane on you. You might be allergic to the donor, the woman, and you might reject it. If you do, your eye's going to hurt and turn red and go crazy. And the longer you leave it on, the worse it's going to get. So this is the number one problem. When they sleep in it and they're allergic to it, it can be horrible. And this is what it can look like a day or two after they sleep in it. This is a picture of a patient that I did early on when I didn't know what I was doing. And these things, I started off so well. So I would start off and I'd have the patient sleep in it and come back in 2 days. Everything would be fine. I did 40 patients with absolutely no complications. I thought this was so easy. And then the 41st patient was this guy, and he came in 2 days later and he looked like this, and it took me a while to figure it out. I know exactly what it is now. So this is a rejection episode, and it's so severe because the guy slept in the membrane for 2 days. You see these large infiltrates, the collection of white blood cells, a lot of injection. You see this white blood cell marshalling going on right here at the limbus, where the red blood cells are dilated. They're bringing in the white blood cells. The white blood cells are gathering up right here, almost like a front line, and then they leap into the cornea, forming these infiltrates. When you look at this on high mag, you can almost see little trails of white blood cells going in, almost like ants going in a line. It's incredible. So this is a severe one. What you're having here is an allograft rejection. It's a type 2 allergic reaction. I don't need to read the slides to you guys. You can see that stuff there or look at it later. But when people have allergic reactions, the antigen is the amniotic membrane. That's what they're reacting to. And so it's recognized as a foreign substance, and antibodies attack it, and all kind of bad stuff starts happening. So and in a worst case scenario, and I've encountered this a couple of times on my own patients, and I've had a couple of docs around the country call me. You can have in a most severe scenario a cytotoxic hypersensitivity, where you get a stromal cell lysis, where you can actually start losing tissue, getting ulceration, and it can go down to perforation if you don't take that membrane off. So you've got a product that can heal someone almost like magic, or if you don't know what you're doing and you're careless, you can almost blind them. I mean, so it's pretty wide range of outcomes with this technology. So you've got to know all facets of it, the good, the bad, and the ugly, okay? Sometimes when the rejection is mild, it'll produce this epithelial rejection line, and anybody that's done these dehydrated membranes will see this after you've done enough cases. And the rejection line usually corresponds to a fold in the membrane. And some doctors will say, well, put the membrane on without any folds and then it won't happen. Well, that's not true, because when you put the membrane on and it has folds in it, and the person and the donor are compatible, it makes no difference. The membrane dissolves quickly, everything's good. The folds don't make any difference at all. If the person is allergic to the membrane, everywhere you have a crease or a fold in it, it seems to cut into the epithelium, and it leaves a lesion that stains like this with this linear shape. Again, in the beginning, I didn't know what I was looking at. Now I know that this is an epithelial rejection line and a sign of an allergic reaction. Here is a real interesting thing, this rejection epitheliopathy, where you see in this patient's had the membrane on for 4 days. She was doing okay. She said she was kind of sort of all right. It was starting to dissolve. You can see here at the bottom where it was starting to dissolve. I decided after 4 days we had got whatever bang we were going to get, and I was going to take it off. Well, I took the thing off, put some fluorescein in, and I saw this pattern here that you see with the fluorescein, and I've seen this many times now. And this is a textbook rejection epitheliopathy from a dehydrated membrane. And you see these lines, these creases, right? These lines. So these are rejection lines, and these corresponded to folds in the membrane almost exactly. You could see, look right here. See that little line? Look at those two lines. See them right there? Same line. This line here is that line right there. It's incredible. So this is what it looks like when it doesn't work. So let's finish up. How do you make this thing better? So you're gonna try and do amniotic membranes. You're gonna try and help your patient. Strategies to improve the outcomes. The outcomes are good, but they're not 100%. So how can you make them better? Well, the first thing is you want to correct any kind of dry eye or eyelid abnormality that's contributing to ocular surface failure. So you want to do all your steroids and your lid expressions and hot compresses and azocytes and Lotamax gels and Zydras. You want to do all of that stuff generally and get them as good as you can before you do this. That seems to make it a little bit better. That's first thing. Number two, if it's not going well, the patient's eyes turn red, they say they're uncomfortable, don't treat them with steroids. I've talked to doctors where they say, man, I'll just put some steroids on them and they'll get through it. No, that's not the way to go. If they're having problems, they're not compatible with the donor. It's better to just stop the session, put them on some topical steroids for a few days, and then decide if you want to try it again with a different donor maybe a week later. But don't try to gut through it. If you realize there's a problem, stop the session and start over later or do something different. But don't keep going. Don't put steroids on them to try to get through it until the membrane dissolves or you decide to take it off if it's a procara membrane. And the last thing, chronic inflammation from this is critical. Chronic inflammation from ongoing ocular surface disease may enhance sensitization and increase the risk of this rejection. So now in some patients, what I do is I stratify my patients into high risk versus normal risk. You know, there's always some risk because you got 1 to 15%. I mean, there's always going to be some risk that somebody might be allergic. So to me, you know, you got to tell people, hey, you might have an allergic reaction. But now there's a group of people I put in a high risk category, and there are people that have got serious long-term chronic inflammation, you know, level 3, 4 dry eyes where they've had inflammation on the surface of their eye for years and years. That seems to make these people more sensitive to having a rejection episode. You know, I've got several references in the science that point to it. We don't have the exact explanation, but anecdotally that seems to be true. So in conclusion, patients' health, lifestyle, other factors affect this wound healing response and their ability to accept the membrane and to get better. And to optimize the environment for making the patient's ocular surface better, you got to factor in all these things here, these bullets, when you're trying to decide if you're going to do this and how much risk you're willing to take and have the patient take. If the patient's old and on a bunch of hormones, if they're real sick, and I mean real sick, you know, barely making it in, oxygen tube in the nose, the whole bit, you know, if they're big, giant, heavy people, all kind of skin disease, allergic disease, cancer patients, people that are immunocompromised. I've had a couple of bad reactions with people that are immunocompromised where I knew they were high risk, and it turned out indeed they were high risk for a reason. People that are real, you know, kind of knuckleheads, you know, where they're smoking 3 packs of cigs a day and not eating good and drinking their breakfast, okay, they might not do as well. But again, you don't know. I mean, I had a guy about 3 weeks ago. He was a straight up alcoholic, and I did him twice, and it was 100 times better after I did him. You know, and I took a chance, but he got better. And people that have had previous surgeries and stuff, that seems to be a risk factor too. So all of these things can affect the response, but I don't let any of them stop me. None of them. You know, I'll explain the risk to the patient, tell them that they got normal risk or high risk, go over the pros and cons, obtain informed consent, and then I try to make my patients better by applying amniotic membrane therapy. That's what I do. So hopefully in this 1 hour I've given you a little bit of impetus to get started if you're not starting. If you've already started, maybe giving you a little bit of push to do more. If you've started and seen stuff you don't understand, hopefully you understand a little bit more what's going on now after listening for an hour. So hopefully that's what we got done. I appreciate everybody listening. I'll be available for the next hour for any kind of questions, and I'll type in answers if necessary. Thanks everybody for listening, and have a good day.